So I have one disclosure here. Some of the work is funded by the Agency for Healthcare Research and Quality. They are not on the hook for anything I say. Okay, so I'm going to just give away the end at the beginning, so you don't have to pay attention to anything with two things. So here's my summary and take-home points. And I'm going to spend most of my time talking about outpatient ambulatory care. Measurement and feedback is a requirement and actually might be the most effective single intervention. We usually think of measurement as like measuring the outcome, but it actually in and of itself might be the most effective intervention. Feedback we give to clinicians cannot be too simple. And then for clinicians, we have to help them address perceptions around patient desire for antibiotics and patient satisfaction. And at the same time I'm giving the talk, I'm going to be tweeting out references and kind of summary tweets about it too. I've got a Twitter buddy here. We've already traded tweets. So, and I'm using the hashtag NebSteward2022, and yeah, you'll see the tweets there. So here's what I'm going to talk about. Two projects. One, a project we did in the Northwestern urgent care practices, and then another one in the Agency for Healthcare Research and Quality Safety Program for improving antibiotic use. Both of these were published last month, so hot off the presses. And then I actually want to do the talk kind of backwards. I'm going to tell you the results first, and then I'm going to unpack the interventions, because I think that's what people want to know to kind of take away. So I'm going to talk about measurement and reporting that I already alluded to, peer comparison and what I think is the right way to do it, pre-commitment that Dr. Kabani already mentioned, and then a few notes about communication training, and hopefully we'll have some time for questions and discussion. Before I get into all of that, I have to make a plea for the group to recognize the importance of ambulatory stewardship. I know stewardship is historically an inpatient and long-term care thing. There are 1.1 billion ambulatory visits in the United States every year. An antibiotic is prescribed in about 10% of them. So the volume of antibiotics prescribed in outpatient dwarfs the amount of antibiotics prescribed in long-term care and in the hospital. Not to say it's not important, not to say CRE is not horrifying, but if we're going after total volume of antibiotics, the vast, vast majority of it is outpatient. I and colleagues have done a number of studies trying to get our hands around the appropriateness of all outpatient studies, and Dr. Kabani alluded to this as well. Here was one from 2019. Where we used market scan, and we coded all, and I forget how many tens of thousands it is now, ICD-10 codes for their appropriateness for ambulatory antibiotic prescribing, and found that only 13% of 15 million prescriptions were clearly appropriate, 36% were potentially appropriate, 23% were clearly inappropriate for things where there was no infectious diagnosis associated with the antibiotic prescribing. And then also sort of horrifying, 29% of the antibiotic prescriptions were not associated with any diagnosis code at all. So there's this huge problem with antibiotic prescribing outpatient where, and a lot of what I'm going to talk about is going to be focused under the spotlight that we can measure, where a patient made a visit and there's a diagnosis. And the antibiotic went to the pharmacy, but there's a lot of antibiotic prescribing that kind of happens outside of that, and it's probably between 20 and 30% of all ambulatory antibiotic prescribing. Okay, so first project I'm going to talk about is this urgent care project we did in the Northwestern Medicine. That is the health system where I work, urgent care practices. Urgent care, fairly or unfairly, gets a rap as a place that is a antibiotic mill, that people go there to get seen, that you come in with a sniffle, you get your Z-Pack. They operate on volume and patient satisfaction, and they don't have a longitudinal relationship with the patients like we do in primary care. And so the most efficient thing to do from a business perspective, see people quickly, give them a Z-Pack, and move them along. We noticed something similar in our own urgent care practices. We now have 23 of them, but when we did this project, there are 17 urgent care practices we'll look at where there was a high rate of inappropriate antibiotic prescribing, and we were mostly focused on clearly inappropriate antibiotic prescribing for acute respiratory infection. So where the clinician made a diagnosis of cold, flu, acute bronchitis, where the right antibiotic prescribing rate is 0. And we did a bunch of stuff. And so I'm going to spend, like I said, I'm just going to give you the results first. So here's a run chart. And of course, these two projects that I'm talking about that just came out happened during the COVID pandemic. Focus on the red line first. That is the rate of our stewardship target, which again should probably be around 0%. And we monitored things through fiscal 2019, so that's from August 2018, and then you'll see a line that says intervention start, and we're feeling very self-congratulatory that the red line starts going down because we're doing stuff. Then the COVID pandemic hit. Dr. Kabani sort of showed a graph like this, and you'll see loads of graphs where you notice both the volume of visits goes down, so the red mountain in the front is the volume of visits. That gets tiny, but then the rate of antibiotic prescribing goes up. So the actual volume of antibiotics is lower, but we often see funny things like that when things happen, and then the volume sort of returned as well. We also, the black line is a diagnosis shifting target, or a diagnosis shifting measure. So we were very concerned that people would learn what the clearly inappropriate diagnoses were, and all of a sudden nobody has acute bronchitis and everybody has a sinus infection and pneumonia. Eliminating the diagnosis of acute bronchitis is not victory. Like, that's not what we're going for. So we're also measuring a parallel measure that captures a bunch of other stuff, and I can talk more about that if there are questions. People also worry about satisfaction. So what this graph shows is the three panels, top to bottom, are 2019, 2020, 2021. On the x-axis is the antibiotic prescribing rate, and on the y-axis is the individual clinician's patient satisfaction score. And what you'll notice as you go from 2019 at the top to 2021 at the bottom, the bubbles kind of are scattered all over the place at the top one and kind of shift over to the left to lower antibiotic prescribing rates. And the good news is the satisfaction scores actually went up. They went up from 83% to 89% of people giving a top box satisfaction rating of patients. And we sort of reduced the variability and kind of eliminated a lot of inappropriate antibiotic prescribing. Okay, and then we also want to tell you about the Agency for Healthcare Research and Quality national program for improving antibiotic use, and a little bit more detail about this one. We enrolled 467 primary care and urgent care practices from around the country. Again, this was conducted during 2020, right in the face of the COVID pandemic. 83% of the practices completed the program, 75% submitted complete data, and it ran from December 2019 to November 2020. And what we collected data from these practices, and I'll show you a slide. That was probably the most challenging thing we did, and we can say more about that in a few minutes. We tried to engage everybody in the practice. A lot of interventions in ambulatory practices just focus on clinicians or prescribers, and we tried to engage everybody because if somebody walks in and gets sympathy from the person at the front desk saying, "Oh, you seem really sick. You should get that checked out and maybe get an antibiotic," poof, right? You've kind of ruined the patient's expectations. We conducted monthly webinars, audio presentations, provided educational tools, and then even had monthly office hours where people from the practice could call in. And for this, our primary outcome was antibiotic prescriptions per 100 acute respiratory infection visits. So a little bit bigger group of diagnoses than the clearly inappropriate prescriptions in the prior one. This is the practices that participated. So the left column are the 389 practices that remained in the safety program kind of after the COVID pandemic hit, because we lost a whole bunch right when that happened. And 292 submitted complete data at the end, which, again, practices had a lot of trouble providing data. We gave them, it was basically an Excel spreadsheet about how to fill out their monthly data, but it's a struggle for a lot of practices. And these are pretty small practices. So these are, the mean number of clinicians, 10, 13, so these are not huge. 42% primary care practices, 41% urgent care, and so on. And here's the main findings. The bars are visit volume. So you'll see the same thing I showed you on the urgent care study where the volume was kind of going up as expected during the winter at these practices. Then the COVID pandemic hits and This is for all acute respiratory infection visits, and so, we didn't want anybody with any respiratory symptoms coming into primary care practices. So the monthly visits went below 100, the average per practice, and then it gradually kind of crept up again. And we see the antibiotic prescribing rate, that's the line for acute respiratory infections, kind of held steady, went up maybe a little bit at the start of the pandemic, and then gradually went down, and there's a statistically significant difference from the beginning to the end of the program. But we also looked at, I skipped over overall antibiotic prescribing. So we also looked at all antibiotic prescribing at these practices, not just for acute respiratory infection visits, and saw something similar. Again, this gets at that diagnosis shifting. It's great if we change the target measure, but if overall antibiotic prescribing doesn't go down, like we actually, from a public health perspective, are not winning. So this looked good too. All right. So let me unpack a couple things I mentioned. So first thing, measurement and reporting. And like I said, a lot of those primary care practices from the AHRQ program, that was their major struggle, was getting the infrastructure, the people, the technical know-how, the time to kind of get their data together. And I want to make a couple points based on this results graph from a randomized controlled trial we did of a bunch of behavioral interventions in primary care practices that was published a while ago. But your eye will naturally go to the comparison between the control line and the intervention line here, peer comparison, which I'm going to say more about in a minute. But I actually want you to focus on the control group. Okay, so first off, one caveat is this line is way smoother than reality. So the way JAMA had us model the data makes the data look a lot smoother. So that's a little bit of an artifact. Like even the fact that you'll see before the intervention period, the antibiotic prescribing rate is going down, which is a little weird, but that's an artifact of the way we modeled the data. But in the control group, in this study, these are people who knew they were going to be in a randomized controlled trial where we're going to be watching their antibiotic prescribing. About 75% of the eligible clinicians signed up to do this, and we know that the eligible clinicians had about a 10% lower antibiotic prescribing rate than the clinicians who didn't sign up, right? You're really bad at this, like I don't want anybody watching. So we've already got the good doobies enrolled here. As soon as the program started, their antibiotic prescribing rate dropped immediately by 10%, and then despite us giving them no feedback over the course of the study, their antibiotic prescribing rate continued to decrease throughout the study. And in absolute terms, even though you're really focused on the difference between peer comparison and control, in absolute terms, the most effective intervention we had in this study was being in the study, right? Being in the control group. So don't underestimate just measuring it and telling people, when people know they're being watched, their behavior changes. And so don't sell that short as an intervention itself. We think of it as the outcome, but it actually might be the most effective intervention we have. Okay, so let me say more about peer comparison and how to give feedback. So in that group, that was probably, of the interventions we tested, peer comparison was probably the most effective thing we did. And we often make many mistakes when we give feedback. And so how many people here, as one example, get a home energy report about like how much energy you use at home? Like how many people get that? Like a bunch of people. What is on that report?
How much energy you use.
Okay, right. So it's how much energy you use.
Wattage or whatever it is, or kilowatt.
Right. So how much energy you use. What else is on that report?
Per month in comparison to previous years.
Okay, so your own comparison to previous years. I bet there's other stuff on your reports, or people don't even see it, right? This is a good point, because you're like, I can't even remember what's on the report. And we're doing the same thing to clinicians, in a similar thing. Yeah, what else is on the report?
Tips on how to reduce your energy use.
Tips, okay, that's good. So you're telling me to do something, like what am I supposed to do? So giving that feedback right away. I bet there's a line there that says something about your efficient neighbors, like how you compare to your efficient neighbors. And so that is a key point, is to key feedback off of a high-performing group. Do not tell people where they are on a bell curve, because the poor performers will do better. The good performers will have a boomerang effect. You'll reduce variability, and the mean will not move, okay? So you have to key feedback off of top performers. The other thing that's on that report often, I've seen this less recently, but when I first started giving this talk, people said this all the time. Does anybody have like a smiley face or like a thumbs up or some like icon that's like, good job? Anybody have that? So I see one nod, good job. Or do you get the face that's got the horizontal line for your mouth, right? That's, So the other thing, one of the people who helped us design our feedback was part of a huge program that studied hundreds of thousands of homes in the LA area about the most effective way to give this feedback. And it turned out giving some quickly, easily interpretable, emotional judgment about how somebody was doing is key. So people have to understand, are they doing a good job or a bad job right away? And we mess that up all the time, and I'll say more about that in a second. So what we decided to do was we told clinicians, you're a top performer, which is great. And we thought we'll key this off the top 10 percentile, but it turned out for what we were measuring, 20% of the doctors had an inappropriate antibiotic prescribing rate of 0. And this is like Lake Wobegon, where everybody can be a top performer. And challengingly, we told everybody else, you're not a top performer, okay? And this is a bunch of doctors who don't like getting feedback like this, but that gets your attention, and we were ready for all of the blowback we got. We were very certain about the data and what we were measuring, so we could go back and say there's absolutely nothing in these patients' charts that indicates they should have gotten an antibiotic. And so that is a emotionally salient, simple feedback that keys off of a top performing group to try to move the mean towards everybody can be a top performer. So happy to answer more questions about that. A mistake we make is we give people way too much data. So this was from a study in Switzerland, never mind the fact that it's in German, where they were like, we gave them the feedback and their behavior didn't change. This is like way too complicated to sort of figure out. It's like how you're doing and how you did last month and for what diagnoses. And you know, a clinician will look at something this complicated and be like, I can't figure this out next, right? We made the same mistake in the AHRQ program. Like, I think this is feedback for a clinic towards the end of the program, and each of those columns is a month. And we did tell them if they're a top performer in that top row, and you'll see in this example, it's like no, 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 no. Still too hard to figure out, right? You need to be able to look at this and understand, are you doing a good job or not right away? This is my own quality feedback report that I get from Northwestern Medicine on a whole variety of topics. So you'll see things like quality measures on breast cancer screening, colorectal cancer screening. There's a section in the middle there for potentially inappropriate antibiotic use. Opioid prescribing is in here too. Better, but I still don't love this. This is, we're happy to tell people they're doing a good job with the green circles. But every cognitive defense mechanism I have, that my perception of myself as a good, caring doctor, I will look at this, think of some patients, like it's green, I'm doing an okay job, and not change my behavior at all. Like I have every psychological reason to do that, and I think we overcomplicate this feedback like this. Okay, pre-commitment. Dr. Kabani referred to this. And we had done a randomized controlled trial of a commitment poster where we had, and this is we've updated it, and what the CDC has available is much better than what we initially tested. But a poster that has a lot of detail about how we're committed to only prescribing antibiotics when you absolutely need it. But a key feature of the randomized controlled trial that's tough to replicate is we actually had clinicians at the practices put their picture on it, sign it, and blew it up to a poster. So they are like invested in it. And there's something called the IKEA effect, that it turns out that we endow more value with things that we have worked with and handled ourselves. So that futon that you built with all of those Allen keys, you love it more because you put it together. And same idea here. We're trying to use the IKEA effect to get buy-in from the clinicians. And again, it had language like, yeah, your health is very important to us. As your doctors, we promise to treat your illness in the best way possible, et cetera, et cetera. But, too complicated, and I'll show you some other data about that. So we randomized 14 clinicians, stratified them by high and low antibiotic prescribing, and measured their antibiotic prescribing at a 48-week baseline period and a 12-week intervention period. The control was just the CDC at the time. It was the Get Smart About Antibiotic poster, so that was the control group, and evaluated about 1,000 non-antibiotic appropriate acute respiratory infection visits. And there was about a 20% reduction in antibiotic prescribing among the clinicians who were randomized to the commitment poster, the personalized commitment poster. So I think we can do better. We've simplified the poster. So this is actually what we used in the AHRQ safety, antibiotic prescribing safety project. That's got the main message a lot more clearly. There's space at the bottom right side for people to put their own picture on. We're going to make this, and I'll have several ads for the resources from the AHRQ program throughout the remainder of my time. And then here's what we used at Northwestern. This is one of the interventions we used in our urgent care, and we also put this up in our primary care practices too, where it's sort of the main message. And one of the reasons to do this, I alluded to the fact that interventions you do have to help clinicians with their perception that patients are there to get antibiotics. We think the way that the commitment poster works is that we've gotten the clinician to commit to not prescribing antibiotics. We've told the patient, most importantly, the clinician knows, the patient knows the clinician's pre-commitment, right? And so that diffuses the default mindset of the clinician that this person is here to get antibiotics, and holy cow, how do I get out of here? And either just give them the Z-Pak or not. But this kind of hopefully changes the mind frame a little bit, like, oh, this patient knows that I've committed to only giving them an antibiotic when it's actually helped, or when it would actually help them. So that's the underlying psychology behind pre-commitment posters. Okay, and then finally wanted to talk about communication training because, like I said, you got to give people something in place of where they are before. So a lot of clinicians' default mindset is I will do everything I can for my patients, to the ends of the earth, no matter who tells me what. And I'm worried about them, and I'm a little concerned they have some infection that I don't know about, and it seems to me the safest thing is to just give them an antibiotic. And you need to replace that with a safety concern about the antibiotic itself. So that's what I talk to patients about. And actually a colleague of mine, Mark Friedberg, has this great phrase that he's like, look, you have a cold now. If I give you an antibiotic, then you're going to have a cold and diarrhea. So which I think is a nice, simple thing. And like a phrase I often use is, this antibiotic, for what you have, the antibiotic is more likely to hurt you than help you. Right? So I'm still helping the patient. And then replacing that sort of advocate for the patient with a little bit more professional ethos. It does feel a little paternalistic, but you're sort of adhering to your professional responsibility. And so along these lines, we had a whole webinar. As one of the webinars was about communicating with patients and families about antibiotic decisions. And here's a couple scenarios we worked through. So, my doctor always gives me an antibiotic for cough. Or another, you're seeing a colleague's patients, and what do you do? And sort of giving people the words to address that. So a lot of newer evidence that antibiotics have more side effects than we appreciated before. Talk a lot about C. diff, talk a lot about drug interactions, prepping people with that. Antibiotics are the only thing that's ever helped me get better. This is a tough one. They've taken the Z-Pak every time they've ever had a cough, and they've just kind of never waited it out. Some other phrases here. Good news, this time you have a virus. Antibiotics don't fight viruses. This has a little bit of that phrase I was telling you about before. You're going to get diarrhea, and then really focusing on pivoting to symptomatic treatment and doing something positive for the patient. Rita Mangione-Smith, who I believe is now at Kaiser in Washington, has this great phrase about always pairing a negative statement with a positive statement. So it's always, you don't need an antibiotic, and never stop there. because whatever the patient says next, we are going to perceive as a request for an antibiotic. Like, are you sure I don't need an antibiotic? Or, and so always phrase it. The good news is you don't need an antibiotic, but let's think about some things to help you get better and move on from there, something productive like that. And then along these same lines, we had a Julie Simsack, Sarah Keller had this paper in Mayo Clinic Proceedings last year, I believe, or 2 years ago. Same idea. There are these stereotyped phrases we get from patients, including the two I already alluded to, but three more were, number 3 here is like an important life event coming up. Like, I have a wedding to go to. I'm taking a plane trip, which always from a logical perspective struck me as weird. It's like, I'm getting on a plane, like I have a cold and I'm getting on a plane, so I need a Z-Pack, which microbiologically and metaphysically does not make, like, what you're doing in the future does not affect what's happening now. Somebody else in their family got an antibiotic for the same symptoms is number 4 there. And then kind of this economic imperative. It's like, I took all this time off from work to come and see you, and you're giving me nothing. And like, how to address that with a positive statement too. So those and others are in this paper. And things you can do with every patient, conveying that the patient's well-being is your primary concern, recognizing that their suffering is real. So, phrases like, you just have a cold, pat, pat, not a good strategy. Affirming the patient's decision to seek medical attention to rule out more serious illness. Like, we can do that with everyone, and that is good. Okay, and then last thing, I've already sort of put in a couple ads, but here's an even more of an ad for the forthcoming AHRQ program resources. And I was gratified to see, I too was looking through the CDC Stewardship website, in tandem with what we were doing in ambulatory care. The AHRQ antibiotic safety program had an acute care and a long-term care wings as well. Resources from those two things are already up on the AHRQ website. So if you look for AHRQ antibiotic safety, you will find resources for acute care and long-term care. And the good news is that the updated CDC website links to those. And there's a little bit of overlap, but they're kind of a little bit distinct. I feel like the CDC is much more strategy and people, and the stuff we have in the AHRQ program is more about culture, communication, and kind of more on the ground, like what do you do with individual people as well. And so one thing all 3 of those domains used was a construct we use of the 4 moments of antibiotic prescribing. This is a little bit different in acute care and long-term care, but for ambulatory care, the 4 moments are, does my patient have an infection that requires antibiotics? Do I need to order any diagnostic tests? If antibiotics are indicated, what's the narrowest, safest, and shortest regimen I can prescribe? And then critically for ambulatory care, and this actually is part of Rita Mangione-Smith's communication training too, is a backup plan, because people always feel like the antibiotic is the backup plan, but you actually need to give people, what to expect. You have acute bronchitis. The median duration of a cough from acute bronchitis is 3 weeks. If you've coughed for 5 days, that is completely normal. It's 3 weeks, and an antibiotic, it's 21 days. So that follow-up plan is key. You'll see on the website the areas that we sort of focused on, developing and improving antibiotic stewardship activities in the practice, learning strategies, and then we also do have things about specific infections. So, and it's kind of the common ticket items: pharyngitis, sinusitis, colds, acute bronchitis, urinary tract infections are all there too. And then this is what the website looks like right now. Unfortunately, right now the ambulatory care toolkit button doesn't go anywhere, but we're supposed to have everything finalized. I think it's this month or next month, so it will be within the next couple months. Should be up. And let me end with my summary points and take-home points. So I told you, measurement and feedback is a requirement, and don't underestimate it as potentially the most effective single intervention we have. 2, feedback cannot be simple enough. 3, for clinicians, help them address perceptions around patients' desire for antibiotics, and then also this perception about patient satisfaction, like how do you keep patients happy as well. And so with that, I will stop and happy to take questions and have conversation.